For those who are waiting, we are live with the ASRA Pain Medicine Regenerative Pain Medicine Special Interest Group live stream. We will be starting in 1 minute. And I hope everyone is excited for this live stream. We have a bunch of experts, and it will be very educational. Thank you for your patience. So thank you everyone who's joining. We are here for the ASRA Pain Medicine Regenerative Pain Medicine Special Interest Group, or SIG, for our first live stream of the year. We have a group of experts joining us today for a very lively discussion on a quite interesting and popular topic in the news. Before we get to the live stream, just a couple of housekeeping notes. I know everyone wanted the best, but he cannot be here. Raj is not here, so I guess I'm what you get for the host today. But just some housekeeping before we start. We have the spring meeting with Steve Haskins over at HSS in my backyard as the chair. Early bird special is till tomorrow or 2 days from now. Still, you could register and get the early bird discount. It's in the Diplomat Beach in Hollywood, Florida. We're celebrating the 100th ASRA celebration from Gaston Labat. We have a lot of videos and a huge party after for the previous winners and the former chairs of ASRA, Pain Medicine. It should be a lively meeting, and I'm looking forward to seeing you there. Also, back in March, we have a virtual chronic postoperative pain symposium. It's a one-day virtual program. It was so popular last year, we brought it back. Bias, I'm one of the instructors teaching some fluoro and ultrasound and another great group. It's a nice Saturday afternoon, world-renowned experts, and 8 CME credits. Looking forward to seeing you as well. And we have in June in Chicago, ASRA Pain Medicine's famous Pain Medicine and MSK ultrasound cadaver course, which goes hand in hand with the topic we're going to discuss, because a lot of these regenerative pain procedures are done under ultrasound guidance, and you can learn a lot of these techniques in the course. So again, we're joined by a large group of experts, and I'll introduce them one by one as they come on the show. We have Christine Hunt, who is an assistant professor and vice chair of quality in the Department of Pain Medicine at Mayo Clinic in Jacksonville. She is boarded in physical medicine rehab and pain medicine, treats patients with a variety of disease processes, and she is the chair of the Regenerative Pain Medicine SIG. So thank you, Christine, for organizing this. Out of Duke, we also have Thomas Buchheit, who's the director of Regenerative Pain Therapy Program at the Duke Center for Translational Pain Medicine, also known as CTPM, which is a lot easier to say. He practiced clinically both at Duke and the Durham VA, where he treats osteoarthritis and musculoskeletal disorders. And he is the practice advisory liaison for the Regenerative Pain Medicine SIG. We have Yashar Eshraghi, who is the program director for Pain Medicine Fellowship Training Program at Ochsner Medical Center in New Orleans, Louisiana. And he is the newsletter co-liaison for the Regenerative Pain Medicine SIG. And last but not least, we have Dmitri Souza, who's a clinical professor of anesthesia at Ohio University and Western Reserve Hospital. He's part of the board of directors at the National Physician Symposium, where he teaches pain medicine, and is also the vice chair of the Regenerative Pain Medicine SIG. Thank you all for joining us. This is a free SIG for ASRA. They have a large amount of information on their SIG homepage. In addition to the chat group, they're all accessible. At the meetings, you will find them. So thank you all for joining us this evening.
Thanks for having us.
So regenerative medicine, hot topic in the news. We see it on CNN, all the news stories. It's flooding Twitter, social media. Everyone's asking about it. So why were you all motivated to incorporate regenerative medicine into your practice?
Let me tell you a personal story. That's how it started about 10 years ago. I had a partial tear of the radial collateral ligament. The elbow was not working. Therapy did not help. I'm not good with medicines. Was thinking about surgery. And then PRP came into the picture. It was like about 4 months of limited driving and other. It was pretty hard actually. But after the first injection, PRP, I got But in a month, the pain was gone, and I checked the ligament. 3 months later, it was healed. So that's how it started for me.
Anyone else?
I would say, in my mind, this is a kind of common question to answer, and we have been trying to answer for decades for chronic pain. And we have been looking for a solution to not only control the pain, and we were trying to maybe reverse the clock or cure the chronic pain. You know, the standard practice that we have, it mostly relies on physical therapy, some interventions that we are using, and most of them include steroids or neuroablative, maybe sometimes like a destructive procedures. So regenerative medicine mostly is an attempt to find a way that instead of using destructive procedures or some other medications that comes with, I would say, that huge bag of side effects and complications, maybe starting the route to offer our patients some type of treatment that have less side effects and maybe a curative approach for the treatment. We're not there yet, but obviously this branch of treatment, not only in chronic pain, in medicine in general, as a regenerative treatment, it's an attempt to treat and offer a different sort of treatment for patients, including chronic pain patients. In my mind, this is something that I can offer for my patients, and as a physician see maybe in the future, we treat our patients in more effective way. And obviously this is a type of treatment that it's autologous. Maybe in the future will be much more off the shelf, but this is a different type of treatment that it's kind of like a going outside of the current standard of practice and giving better options to help the patients in the future.
So are you finding yourself, you're offering it to your patients more, or people coming to you, hey, I want PRP or BMP? What do you guys are seeing in your practices now?
We don't advertise it in our practice. It's more like when patient would ask about it, we have the tools and equipment to satisfy patient request, of course, if it's indicated. But overall, it's a mouth-to-mouth kind of advertising. What is your experience with those?
Pretty much the same thing for me in my practice, because we are academic practice, sort of on a hybrid practice, functioning like an academic and hybrid format. So we don't advertise regenerative treatments. Most of the patients, when they come to us, as Dr. Souza mentioned, that they come and ask for the treatment. The ones that are read it online or heard from a friend that had a treatment and had good results, and they want something different. But sometimes I offer to the patients that I see that they failed other treatments, conventional treatments, and they are, in my mind, potentially a good candidate for regenerative treatment. That's the time that I carefully, because obviously when you're offering treatment for a patient that it's not covered by insurance, it's out of pocket, it's cash treatment. So you have to be very careful about how you present it to the patient. So they kind of like, it does not get received as a wrong message, even if you are an academic practice. So I carefully introduce it and ask them to go and read about it. I never tell the patients that what I want to do and say that like this is potentially a treatment that it's available. Give them some resources and say that I'd like to think about it, read about it. Let me know if something that you like to do.
So we just had a question come in. So Christine, maybe you could help us out with this. Where is it in the treatment algorithm that you see regenerative therapy? So let's say usually in our chronic pain, it's physical therapy, maybe Tylenol, NSAIDs, not helping 8 weeks, whatever the insurance says, 12 weeks, maybe it's radicular pain, we offer an epidural. So in this chronic pain, tendon, ligament, joints, where is regenerative medicine? And I'd like all your opinions on this one in your algorithm, if you have it for an algorithm.
This is a great question. You put it very, very much right, in my opinion. In our practice, we're really focusing on regenerative medicine for musculoskeletal conditions. We don't advertise this. So it's, even though people can get information about regenerative medicine at Mayo Clinic through the Center for Regenerative Medicine, that kind of helps give general information to patients and then gets them plugged into the correct kind of department or service line at our institution where people can find out more about this. In chronic pain, we're really focused on musculoskeletal indications. So we're not doing epidurals with platelet lysate, for example. We're not doing peripheral nerve injections with PRP, for example. So we're really thinking about, for musculoskeletal pain, we'll treat all different types of tendinous problems or joint pathology, things like that. A lot of it is driven by patients who are kind of curious in this and who might be sort of approaching this and have specific questions about regenerative medicine. The fact is that since this is not something that is paid for by insurance or that's in those traditional treatment algorithms, it's not necessarily something that's going to make an appearance in every single patient workup. The types of patients who might approach us for this sort of therapy are patients who are generally a little bit on the younger side. And also, definitely patients who have more of a sports injury type related problem. But we treat plenty of patients who have more chronic pain, chronic degenerative pain, osteoarthritis, things like that. And so we're really thinking through, number one, do I really clearly know the pain generator? And there might be other types of injections or procedures or evaluation you need to do to really kind of confirm that you feel confident that you know what's really causing the pain before you think about offering a therapy like regenerative medicine for that problem. And then really thinking through, what type of product might be appropriate to approach this, condition that I'm treating. And I know that we'll talk a little bit more about that, I'm sure, during the course of this live stream. But it doesn't enter into the treatment algorithm or treatment plan for every patient. But for those who are interested in regenerative medicine, we have that very same thoughtful conversation that Dr. Eshraghi and Dr. Souza spoke about in terms of just giving patients information, really being very clear to them about sometimes the experimental nature of some of these therapies, and just encouraging them to, kind of understand what's out there and give them the best information that we have to help support their decision.
So, Thomas, you guys have a whole CPTM system over at Duke. How do you guys fit this into your algorithm? Because I'm sure you have treated a little bit different than some of our practices.
No, it's a great question, Gary. A couple of thoughts, actually, even going back to your first question of why be in the space to begin with. And I would probably add on to what everybody said. I agree with all of that. I'd probably add on because I think it's the future of musculoskeletal care, non-surgical musculoskeletal care, and probably treatment of neuropathies. With that said, though, there's a whole lot we don't know. And, but there are indications. We also need to be careful. We're treating things that are likely going to respond. If you're treating bone-on-bone arthritis, you're probably a little bit less likely to see a good response with, growth factor and platelet-derived products. And in the end, there's going to be different algorithms that are going to develop over the coming years. They're going to be different for the hip, different from the knee. We've already seen that, where there may be different products that are better for joint or tendon or ligament versus others. And so there really isn't a standard algorithm. I kind of have a mental algorithm for grade 2, grade 3 OA of a knee. I have a different algorithm for rotator cuff tendinopathy and a different algorithm again for trochanter tendinopathies. So I think it really is like Christy was saying, it's very disease specific, it's very condition specific. And I think one of the things we're always trying to do is make sure that we educate patients coming in. They see this magic and hear this magic of stem cells and this magic that goes on. And it's not magic. These are biologic therapies. They can induce a healing cascade. They can be very complementary with other things, including exercise and diet and everything else. But we also have to kind of tamp down these thoughts that they're panaceas, which they're not, but they can be very effective therapies as part of a whole package.
So prior to this becoming more mainstream, we've had local anesthetic, maybe prolotherapy, a lot of steroids. We all remember the whole compounding fiasco from a few years ago that was all over NPR and the news, and we have limited access. So what's the regulatory environment for regenerative medicine? And I'm going to put this in quotes because it's a wide range of stem cells over here that people always ask. And what do you think is the safest way to use it to someone in practice or to offer it in your practice? and we'll just go around. We'll start with Yashar, and we'll go all around the corner just to get each of your opinions on this.
Sure. So this is a wonderful question, because whoever wants to start regenerative practice need to be really familiar with these guidelines, FDA rules and guidelines, for two reasons. Obviously, for your own safety, for your patient's safety, because if you are not familiar, you might get approached with different type of treatments that come from different companies or advertisements, and you adopt those in your practice and become a target for FDA regulatory people. So like it's mainly comes to understand that what are the FDA Code of Federal Regulations. There are two types, like we always kind of compare them as 351 criteria versus 361 criteria. So 351 is very strict about like if somebody trying to develop a drug or a new treatment. So those are like any biologics that needs to get in like IND application and go through the phases of application through FDA processing. The one that it's normally helps us to use PRP or some of the other biologics in chronic pain is the 361 criteria. So this is mainly for physician practitioners in the US, less kind of intense regulatory environment for that. So briefly, it means that if you're using a biologic, it should be minimally manipulated, it should be homologous, and not reliant on systemic effect, and you cannot combine it with other medications and articles. So that's the main way that you look at it. And FDA have been some updates around this, that you have to always stay in touch with the latest updates. And our SIG actually has, like if you go to our webpage, you can always access the latest updates on FDA rules and regulations. The last one was came out as May 2021. So they made some updates and made actually the rules a lot more strict. And we can talk about it a little bit more, because it changed the scenery a little bit for bone marrow concentrates, and mainly for adipose tissue derived stem cells and MSCs, because they don't consider them anymore as homologous treatment, and because of the enzymatic degradation and mechanical disruption that for isolate those cells being used, so they don't really consider them as minimal manipulation. It means that you can't really use them in a regular practice setting anymore. So these are important things that you need to understand. Otherwise, you can really put yourself in a major trouble with the FDA regulatory system.
Anything else to add about the regulation from Dmitri, Christine, Thomas that we didn't touch on? And that was pretty comprehensive, Yashar, so thank you.
I would say please never use the term FDA approved treatment, right? So just because the FDA, for example, has said that platelet-rich plasma is not considered HCTP or, kind of human cellular therapy or product, and is not subject to some of these same regulations that bone marrow aspirate concentrate might be, or adipose tissue might be, that does not mean that it has been approved by the FDA for any type of treatment or disease. So be very careful about some of these kind of words and kind of communications and conversations that you're having with your patients, right? This is a tricky regulatory environment. Once you understand it and do a little bit of diving into it, it's actually not very complicated, right? That's actually one thing that I really love about our SIG, is that we do a great job of having these conversations pretty regularly. And the FDA has some pretty straightforward guidance, and there's actually some nice, there is a very nice paper that we have for some background on what this means through the SIG. And you can find, any SIG member can have free access to that kind of really does a good job of summarizing some of that. But be very careful and cautious. Sometimes when I'll see these things advertised, and even companies will advertise FDA cleared product, right? Just because a centrifuge has been cleared by an FDA to prepare a certain product, it does not mean that the product that it prepares has actually been approved for any sort of indication, right? So being careful about the sort of language that we use. That was a great description, Yashar. That's just a a pet peeve of mine is sometimes when you hear that language.
And one quick thing, Thomas, hold on one second. I'll get to you in 1 second, Thomas. Just Christine, I know you mentioned that they have every information on the SIG. For all ASRA members, it's free to join this SIG, correct?
Yes.
So they could just join on ASRA.com. And 2, they find this on all the ASRA SIGs. They have a SIG section right on the beginning of the website. You could find the SIG there to join, get accepted, get all this information. And I know you guys also post regularly to the ASRA Pain Medicine Connect community, where people could ask questions about the SIG and find some of those papers. So for everyone who's watching, that's another option. Thomas, we'll get to you if you want to add anything. I apologize.
No, that's good. I was just going to put a plug in for actually Dr. Hunt and colleagues did a very nice fellows course a few weeks ago down at Mayo Jacksonville, and we had a fairly deep dive and deep discussions about the regulatory side. The take-home messages for me with that discussion is, blood-based products like PRP are thought to be fine. So they're processed and made in front of the patient. You're not doing any fancy manipulations or incubation or anything like that. And the other thing is just because somebody tells you or sends you an email that says their placental product or their amniotic product is FDA cleared, don't listen to them because it's just not true. Those allogeneic products need to go through, it's thought 351 pathway. So they need to go through a strict regulatory pathway and check your facts, and the FDA will set that straight. And I think we clarified some of that in our white paper as well.
So I think this is all pretty exciting.
A little comment. That's thank you, Christine and Tom, because this is like very critical point. We had a kind of known incident. I think Dmitri remembers that, and Tom and Christine definitely remember that too. It was in 2019, I guess. There was a product for amniotic cell product. It was manufactured in a company in California, and this product was FDA registered. FDA registered means that you start the paperwork and process, but you don't really have the approval. But they actually started advertising it through private practices. And I remember at that time, a few of my colleagues in private practice asked me about this, reps are coming to us and introducing this type of product. It seems pretty good. I'm going to start using it. Some of them actually started using it, even if I told them, don't, dangerous approach. So then we had a report from FDA that there were several severe complications of this product. Some of these patients required several weeks of ICU admission. And then the examination of these products released that the contamination was from the source. So the product itself was contaminated from the production plant. And so this is a very important factor to look into it. And I'm sure there are other companies that are out there that are introducing these kind of products practitioner environment, and it will be easy to kind of feel that they're offering all these instruments, as Christine said, freely for you, and they say that this is FDA approved. Honestly, we're getting a device approval from FDA. It's a very easy process. You have to just show that it's safe. You don't need any data. It's a very easy process, but it doesn't mean that what you're producing with that instrument is FDA approved.
And I know Thomas and Christine mentioned the fellow course, which we want fellows to get introduced in this, but maybe Dmitri could touch on this. So we're getting excited about regenerative medicine. We see it everywhere. So how would you recommend physicians starting this in your practice? Other than the MSK course and some of Christine's courses, where else could you get the training for this? What is needed? I want to start regenerative medicine tomorrow. What do I do?
So it's a good time to start. Don't wait. There are two common mistakes, with starting regenerative medicine practice. One is people are doing this too fast. They're getting all the options together and advertising and moving too fast. And I don't think it's a good way to do it. But the other mistake is, I think people do it too slowly. They think about it for years and nothing happened. So it should be some kind of medium. And if you look at the FDA statement on regenerative medicine, They mentioned a lot of different products, but they didn't say anything about PRP. It was not mentioned in that critical statement. So I think that potentially opens the door for the regenerative medicine. The term itself, I think we should kind of rethink it, and Christine brought it up in the past. It should be not really regenerative medicine. It's not a correct term. It should be blood-based products, cell-based product, something like this, and it's coming. So I would suggest to start with blood-based products, which is PRP. Get familiar with it. It has multiple applications. The most proven one is for early osteoarthritis of the knee. That produce fantastic results. It's probably less expensive than viscous supplementation and apparently more effective. So that would be a good start. We use it for a variety of applications, and it's not on the first line in the algorithm. But typically, if a patient tried everything else and the patient has indications for this type of treatment, would bring it up. Or patient has contraindications to other type of treatments, like severe diabetes, for example, and you don't want to use steroids on those patients there. And the insurance would not approve viscous supplementation. Why not to try and discuss the platelet-rich plasma, for example? That would be a start, in my opinion.
Do we need any sort of basic infrastructure? I guess some sort of imaging, any special training, or as long as you have a pain medicine fellowship or PM&R-based background with injection-based therapy, anything else you'd recommend training-wise, or ultrasound versus fluoro, combination of both?
So it makes sense to get some additional training, because not all the pain fellowships provide this particular type of training. And we have a program in June, actually, that MSK ultrasound workshop with ASRA, where Christine will be leading the stations on regenerative medicine or blood-based products and cell-based products. There are other programs, of course, but it makes sense to learn more about it before you start. In terms of equipment, you look at some kind of basic equipment. You need to train nurses, and overall, it's not that difficult to start the regenerative medicine practice. It's relatively easy, and we're happy to help. Please communicate through the ASRA Regenerative Medicine Group, special interest group.
Because you guys are all the experts. I know, Christine, you really help out with the MSK ultrasound course over in Chicago. So any preference, fluoro or ultrasound? Obviously, some sort of centrifuge-based system or some way to get the blood-based products for the practice. Anything else that you would like to add?
So, and first I want to say we appreciated so much Dr. Buchheit coming out and helping us with the course. It was, put on by the Center for, generous sponsorship from the Center for Regenerative Medicine, and Wenchen Chu is doing a ton of fascinating research down there into some of these products. But I would say mentorship, this isn't a direct answer to your question, but mentorship is so critical and important here. It's important when we're talking about a lot of advanced interventional therapies, and having a resource, a person, including, not to keep plugging this, but even in the SIG, we do a nice job of working as a community, kind of bounce ideas off of one another. And that really can help you grow, especially in a field like this. When it comes to modality and imaging, when you're thinking about some of these kind of tendon-based procedures, it can be very nice to use ultrasound with some of this. But then we all know that fluoroscopy is necessary for certain procedures like SI joint injections or facet joint injections, for example, and very helpful if you're going to be doing bone marrow aspiration. So a lot of people will do bone marrow aspiration using some kind of ultrasound assisted to kind of visualize some of these structures. But fluoroscopy is a very helpful way to perform bone marrow aspiration in a safe way. So it really depends on kind of what your target is and what you're going for in terms of which imaging modality is most appropriate. I think that at a minimum, having that background in doing an interventional pain fellowship, an accredited pain fellowship, is very helpful for understanding what you're treating, diagnosing, things like that. But beyond that, doing some training for regenerative medicine, which is commonly available in many fellowships today. You can really start in your training doing it. That's how I got started. I was exposed to it as a resident and then throughout fellowship. So can be a standard part of the training curriculum these days. I believe it was Cleveland Clinic that introduced the first formal regenerative medicine didactic into fellowship a few years ago. So this is more and more commonly being taught in training.
And I'd add on to that as well. I think we've all been talking also about the musculoskeletal side of things. That is such a fundamental knowledge set. It's so important for any biologics. And now I'll speak about myself. I mean, I came from an interventional background in spine and pain, and not an MSK background. And I had to go back and really dig deeply into MSK literature, into courses and everything. And so I think any of us who are interested in the biologic space and the regenerative space, I think we should have a base of knowledge of musculoskeletal medicine. I think that includes some ultrasound exposure as well.
Excellent. So we're going to transition in a second to the mechanisms of regenerative medicine, because I think that's important. But before that, I want each of you, Yashar, you can go first, up and coming in the field of regenerative medicine, one thing that may be high impact for clinical practice. Let's hear what you think.
This actually kind of brings one of the things that I wanted to introduce to everyone to read. I think the exosomes are one of the main targets for the future of regenerative medicine. And the research, a very exciting research coming up. I think it's plays an important role in the future of regenerative medicine. And if you guys want to learn more about it, we had an article in SIG newsletter in the last one regarding that, written by Dr. Buchheit and one of my young and talented colleagues, Dr. Hanya Dudemeyer. But this article will be published in ASRA newsletter in May. So if you're looking forward to learn about this topic more, kind of stay tuned for the exosomes, the good, the bad, and the ugly article coming up by Dr. Hanyu and Dr. Buchheit.
I can't wait to read that. Dmitri, what's your up and coming in the field?
I think that allogenic stem cells would be the next big one. You see, the regenerative medicine or stem or cell-based products, they don't really used as a building blocks. They work in pharmacy. Essentially, it's something which attracts other cells. For that, you have to have a lot of cells. And a lot of patients, elderly, for example, they have limited number of those cells there. You cannot get much to produce clinical effects. So when we're talking about allogenic stem cells or like mesenchymal stem cells with a large number, that will likely elicit an adequate clinical response. And there are a lot of studies on the way. If you look at overall regenerative medicine studies, about 10,000 is on the way. So I think this is the future. It's coming.
Christine?
This is so funny. I was going to say exosomes, and then Yashar said exosomes.
You can still say exosomes.
And I was going to say allogeneic. I was going to say allogeneic product, and then Dmitri said allogeneic product. It's like, oh gosh, okay. So these are both great answers. I agree wholeheartedly. I will say to dovetail with the fall 2023 pain medicine meeting for ASRA with the theme of precision pain medicine, I think that I should say I hope, and I think that in the future we'll have a much better understanding of kind of tailoring the correct sort of therapies to pathology and to the patient's age and other medical comorbidities, and also being able to tailor things like recommended nutrition programs and specific rehab programs and protocols to accompany some of these procedures. I think right now, especially when you look at kind of some of the commonly marketed things, as I've heard Tom say before, it's just like, just like if it hurts, rub some goop on it, right? Whether that's steroid or whether that's, biologic, let's ablate it, right? If it hurts, let's just kind of rub our stuff on it, right? And that's not a highly precise way to engage in this sort of field. So I think that in regenerative medicine, we're looking more and more at really tailoring therapy more closely to a specific, not only the condition, but the specific patient and their comorbidities, and how to optimize things from a lifestyle standpoint to really help optimize their chance of response. And
Thomas, anything that anyone hasn't said that you'd like to add to this? Just that
I agree with everybody here. That's my part of the problem, I guess. But so I guess to add on to that, maybe as a segue to our next discussion point, is that perhaps maybe also focusing on the knowledge that these are immune-based therapies. They're not cell replacement. They're not fighting inflammation. They're immune-based therapy. And I think the more we understand those deeper mechanisms, including exosomes, the more we understand the site-specific and disease-specific applications, like Dr. Hunt mentioned. And also, it's also going to start opening up probably more and more allogeneic products, like Dmitri said. So I guess it all comes together, but I think understanding the mechanisms will really help us drive, tailor, and improve these treatments. So I think we're really at the very, very tip of the iceberg here with understanding them.
I think this is all exciting for the future, especially for us as hopefully we age gracefully, but there'll be more options for us. And thank you for the segue. It makes my job a lot easier, Thomas. But we always hear this regenerative medicine. We're thinking of turning back the clock. I know we brought about that it has great or at least very good studies on early onset OA. But how do we describe it to the patients? Like, are we turning back osteoarthritis? Are we actually reversing osteoarthritis? We have great grandma, 95, coming to the clinic, and her knee's been grinding on each other, the bones, for about 2 decades now. Could one little shot of regenerative medicine or PRP or stem cells reverse the whole process? I will leave that up to you to start discussing mechanistic outcomes.
Christy, you want to start this one?
Yeah, I was looking to see who was going to go first. So I think we can hopefully all know and understand that, you know, we can't counsel the patient that, hey, this is going to regrow. This is usually the first conversation that I had, and I at that conference that Tom and I were both at, there was an interesting comment that, you know, we shouldn't shy away from the brand or the name regenerative medicine, because at least everybody knows what that is, right? I think there's some truth to that, but on the other hand, really there's no evidence that there's any clinically significant degree of tissue regrowth or regeneration with any of the current products that are available to be prepared, you know, in the point of care clinical space today, right? So there's no evidence that we're regrowing tissue or things like that. The real discussion emphasis that I have with patients is kind of on pain relief, and that's the mechanism. Like somebody, I think it was Tom, said on this call before, or it might have been Yashar, the idea, the better candidates are probably those who have milder forms of OA or a disease, and so that bone on bone, there's really not much for the product to be able to interact with, you know. And I know Tom will talk a lot about kind of immune-based mechanisms in regenerative medicine and what we call regenerative medicine. But there's not evidence that we're regrowing tissue, restoring people to youth. I came across an interesting news story about a wealthy person who spends $2 million a year and has done that for the last 2 or 3 years to try to make himself age, you know, unage, right, grow younger. And and they're doing he has all these different doctors sort of trying to adjust every single parameter of his life, including regenerative medicine procedures, to try to restore his youth, right? And that is not what's happening here with these products. So that's a very important conversation to have with patients, and to help with those expectations. I've had patients to me come before who don't have any pain, and they say, I just know I have arthritis. My doctor told me I have knee arthritis. It doesn't bother me, but I need to have a PRP injection to cure the arthritis, right? And so that's a great opportunity to provide education, because I truly believe that there are people out there who probably don't necessarily believe that, physicians who don't necessarily believe that, but kind of allow that assumption to go unquestioned, right? So it's very important that we provide good education on that front.
So, and this is and I'll leave this up to you. Maybe Thomas, you could pop in on this, because Christine kind of brought this up, but we hear about mesenchymal stem cells and MSCs. There's a lot of people on the live stream. Obviously, you guys are all experts. Some people are novices in this, or trying to learn more. Talk about some of the confusion of these mesenchymal stem cells. Could you describe the products, or in simple terms, so a basic person can understand it? We're not just going to drop a cell in and you're going to grow new cartilage and all of a sudden you're going to be running like you're 20 again.
Yeah, maybe I'll start, and Dmitri, maybe you can chime in as well, because I think you're the local expert here also. But yeah, there is a lot of confusion about what are stem cell products. And I think some of this started when, you know, our Arnold Kaplan, he kind of looked at ways you can take these mesenchymal cells that are pericytes that are on the vasculature of bone marrow and fat and other things, and you can drive them off and you can culture them up. You can culture them up in lab into cartilage cells, into bone cells, depending with growth factors you put. And I think the assumption was that, well, therefore, if that happens in a test tube or that happens in cell culture, if you inject it into somebody's knee, it's going to grow new cartilage. And that's just not the reality. But the reality is there are probably therapeutic benefits from a lot of these therapies, whether it's bone marrow aspirate, whether it's lipid sourced and other things. And there's been some really interesting data to show that a lot of times the cells don't even live, but they induce a really interesting downstream therapeutic effect that's actually macrophage driven and again, immune cell driven. But I don't know, Dmitri, do you have any other thoughts on that?
I agree that it's a change in the understanding of how this type of therapies work. In the past, we thought, oh, this is a stem cell. I get one from here, put it there, and it's going to be kind of a new tissue there. It's not. The studies showed that even we injected stem cells or allogeneic stem cells in certain areas, pretty shortly, there are only host cells there. They disappear. There is no DNA for outside cells, and I think this is remarkable. This means that those type of treatments and those cells are essentially the triggers of body healing rather than building blocks. We talk about this.
Go.
I would say this is a great point that everybody mentioned. There was a point like Christine was mentioning about the severity of the disease and like a customizing to the patient and like a kind of like a tailored treatment. And it doesn't come only just the disease and like it goes to the type of treatment that maybe we are not as familiar with it yet. And we will kind of find out that maybe in the future, maybe allogenic treatments might be better for certain type of patient population or certain indications, or maybe exosomes or like blood products might be better for other conditions. And there are some conflicting results with that too. If you look at the evidence, when you look at the tendinopathies or intra-articular injections, the results sometimes are conflicting. You look at like leukocyte rich versus leukocyte poor, like there was a shift from what is better for like tendinopathies, what is better for intra-articular osteoarthritis injections. And then like you see, especially where you look at for the knee osteoarthritis, there were results that showed that leukocyte poor is better for intra-articular injections. But there's a recent, evidence that showed that actually you didn't see any difference if you're using the leukocyte rich versus leukocyte poor. So obviously we don't know exactly that some of these details in the efficacy of these treatments, but it makes it exciting because it means that there's a lot to learn for all of us to tailor it and have a better understanding in the future. Tom, I think it wants to add something about it.
Yeah, I'll tell you, Dr. Eshraghi has you've opened the door right wide open for me on this one. But no, and we've talked a lot, mechanisms. But we've talked actually a lot about this in a lot of conferences, and it's really confusing literature. So if you look at the BASA, there are 6 or 7 meta-analyses that show benefit of PRP products for mild to moderate knee arthritis. So full stop. But there have been a couple of very high-profile negative studies recently, and I think the one, Yashar, you're referring to is the JAMA study. The Benel JAMA study was a negative study for knee arthritis, and everybody kind of scratched their heads. But if you look at what they injected, it wasn't PRP; it was just plasma. The platelet count was just over 300,000, so it's physiologic platelets. The growth factors weren't going to be high, and I think my point with that is, I think we've been pushing more and more toward all these leukocyte-reduced products, and I think it's a bit misguided. I think you need the immune response, and to do it, just a bit of a dive here on it. We do all kinds of things that stimulate immune response for therapeutic purposes. Gary, you mentioned prolotherapy. It's a great example. It's an immune stimulant. If you inject dextrose high concentration in your muscle and biopsy it afterwards, you're going to have an inflammatory response in that. But it will thicken tendons and strengthen tendons as well. Exercise, a lot of us exercise. If we are especially into high intensity, that's an inflammatory stimulus. right? IL-6 increases, TNF increases, proteases like MMP increase, but it sets up this therapeutic response afterwards. Surgical microfracturing, that's in controlled injury. Tissue fenestrations, again, controlled injury. So we do things all the time that are causing inflammation purposefully to induce healing. And I think we need to keep that in mind with our therapies as well, and maybe reconsider what we're doing, even with things as simple as PRP, to say that maybe we don't need to delete and eliminate all these leukocytes and neutrophils and monocytes out of there. Maybe they're playing an important role.
I know we touched on this. I know we talked about leukocyte rich, leukocyte poor. We talked about lysate before. If one of you could just give a quick overview about the different types of PRP, the characteristics, just like a shorthand version. They obviously could learn more about from the SIG and doing it themselves. If anyone wants to touch on that, of this group of experts over here.
Dmitri, I know you've talked a lot about this, not to put you in the hot seat, but
but she will. So we'll call on you.
But she just did.
You missed it. You asking me?
Yes, all of us. You have to answer this question.
Okay. So in the past, people used PRP in general for various indications, and that created a confusion about the outcomes. When you don't know what you inject in and you don't know where exactly it goes and what is the pathology is, the results are conflicting. Later on, people figure out that red blood cells are toxic for the cartilage, but that was clear. But what also was found that when you inject leukocyte-rich PRP into the joint, it produced significant inflammatory response. It's very painful. That's one of the reasons PRP is painful. And people figure out that injecting leukocyte-poor PRP into the joint would be beneficial compared to injecting other types of PRP. If we look at the tendons, the picture is reversed. You have to have enough leukocytes to produce inflammatory response for that particular tissue to work. And there are some other variations there, but if you look at this, it's a lot of work ahead to figure out which type of PRP works for which type of indications. And even if you look at the details like leukocyte-rich PRP, for example, there are different type of white blood cells. The neutrophils would produce inflammatory response, cause pain, and maybe damage the, slow down the recovery potentially. If you look at the basophils or some other like B cells, for example, I would like Tom to comment on this. They are essentially immunomodulation type of cells there, and we need them. So it's a lot of things that still in the work, still unknown, but overall, I think with time we're getting better understanding. And I agree that there was an appropriate publication about negative effect in PRP, or lack of clinical effect of PRP, because you have to prove what you inject in there, and they injected essentially normal concentration of platelets there and say it doesn't work. So very important to be careful what you read and how it's presented.
So I think Dmitri and Tom, you guys both brought this up. Different types of leukocyte-rich and poor are better for tendons versus arthritis and cartilage. So does it work? Does the regional anesthesia work the same in these conditions? Are the mechanisms the same? I don't know if Thomas, Christine, Yashar wants to comment on that. Depending if it's tendon or cartilage or just degenerative changes. Are we talking about the same mechanisms here, or?
Yeah, sure. You want to do a start?
You mean basically on like a nerve block? So you're talking, what are you comparing it to?
So just in general, like PRP in general, like chronic joint pain versus like tendinopathy, and we're going to treat, right?
So like intra-articular versus tendon.
Tendon.
Thank you.
That's pretty much my answer will be very similar to what Dmitri mentioned. So the thought process is when you are treating osteoarthritis or intra-articular conditions, you do not want high inflammation. High inflammatory response comes from leukocytes and red blood cells. And red blood cells are, when you are doing the centrifuge, the heme products are very toxic to the cell. So definitely red blood cells has to be out for both products. And I always say, if you want to, so this is kind of a side comment in advice, if you are looking at the product quality that you want to choose for your practice, you look into it how it looks like. If you don't know how to measure the red blood cell counts or platelet counts, if they look pretty red, they're probably not a good product. It has a lot of RBCs in it. But besides that, for intra-articular injections, leukocyte poor, in my mind, and some evidence supports that it's good for intra-articular injections, because you don't want aseptic synovitis causing because of the high leukocyte components. But as Tom said, the evidence is mixed, and it might be different results in the future for that. But for tendon, when you are using for tendinopathies, you need high inflammation, and you want to start the inflammatory response. And leukocyte rich, supported by some evidence, is better for tendinopathies to use the leukocyte rich products. So that's part of it. And as Tom mentioned, in general, platelet counts are important too. So if you're using physiological level platelet counts, and based on some of the studies that used, like published recent study in JAMA, probably you're not going to get any results at all. So you want about 5 to 6 times concentration of the physiological level. And if you go too high, which sometimes advertise with some of the companies, that you get really high concentration of platelets. We know that if you use too high concentrations of platelets, you might actually get a plateau effect and even inhibitory response for healing process. So high concentration of platelets are not necessarily good.
I think what we're all talking around here is a kind of a Goldilocks position, right? You want it not too hot and not too cold, and that's what we're trying to figure out. And that's what this is evolving. I think we all agree, at least I would agree with Dmitri and Yashar, that you want a little more. You want your porridge to be a little bit hotter for tendons and ligaments, and a little bit cooler for joints. But I would argue you don't want it cold, because if you look at the downstream effects, really what you want is you want a macrophage that's going to lay down matrix. It's going to lay down all these beneficial anabolic growth factors and cytokines and everything else. And you want to find a way to turn that M2 macrophage on. And you can do that with white cells. If you do too much, you push it over the edge, right? So I think you want to figure out the temperature of your porridge and figure out how you're going to guide that for your therapy.
I know we spoke a lot about inflammation. I know we differentiate from steroids. A lot of questions that we get, and the one question that came in tonight is, what do you do with anti-inflammatories like Motrin, naproxen, before or after? You stop for a week, 2 weeks, neither? In your guys' practice, or any advice for
We
people?
usually we used to have them stop for a week before, and then not resume until 1 to 2 weeks after.
Mhm.
Now we'll often ask them not to resume NSAIDs until 6 weeks after.
Okay.
So for various reasons. So I would say at a minimum, I would say it's standard practice really to stop anti-inflammatories for 7 days before. And it's not that you're worried about bleeding. It's that you're not wanting to inhibit or interfere with the effect of particularly platelet activity, of course, on the process that's going on. There's very, very, very low risk of bleeding with this. In fact, a trial that we're doing right now with PRP and lumbar facet injections, for example, patients should not be holding their anticoagulants for this procedure. Risk does not outweigh benefit. Even antiplatelet drugs. This is what's kind of tricky, because if they're on their antiplatelets, that's a prescribed medication for a medical condition. It's controversial if you should hold these, but we really want them to hold their anti-inflammatories if they can for a period of time.
What about steroids? And how does it differ from steroids?
So we definitely are not wanting them to take steroids before or after. I mean, again, it kind of depends, right? So if you have a patient who has, a rheumatologic condition, and this is a prescribed medication by their doctor, that's sort of different than NSAIDs, which are an elective, type of treatment. You also want to question, in a patient, what pain condition are you treating for somebody who's on chronic steroid therapy? Is this appropriate? Kind of what's our rationale here and what are we doing? But I would definitely agree with what others on this call have said. I remember years ago talking with someone who was saying, well, gosh, if regenerative therapies are anti-inflammatory and steroids are anti-inflammatory, what's the difference, right? Why would you even do anything other than steroids? And the mechanisms are totally different. And I remember having a little bit of a when I first met some of these folks through the ASRA SIG, one of our earliest conversations was on this neuroimmune mechanism, and talking with Tom and the paper that they put out. What is it, a couple of years ago now that paper came out? 2019.
2020.
Oh, 2020. Yeah, I can't believe how time has flown. I feel like just yesterday I wanted to talk to Tom about this paper. I said this is this absolutely fascinating way to think about this, and now this is and we're like, of course this is how these work, right? But totally different mechanisms, and I would love to hear what you have to say about that.
Yeah, I mean, so we're really thinking about the difference between anabolic and catabolic processes, right? You're trying to build back tissues and build back strength, and that gets back to the NSAID story. NSAIDs shut down some of these anabolic processes. And they've even looked at this in the exercise literature. So if you take a bunch of ibuprofen before you go for a run or before you go for a workout, you actually decrease the protein synthetic processes that happen after that workout. So it just, it's not just platelet degranulation. It's not just growth factor release from platelets, but it's the anabolic process we're trying to incite and have carry forward. And that also gets back to steroids. I think we all agree that one steroid injection here or there is just fine. But when you get these repeated steroid injections over and over again, it starts to turn into more catabolic, and you start to see decreased tissue resiliency and decreased tissue health. So
I agree with that. In our practice, very similar to what Christine said, I ask all the patients to stop NSAIDs 7 to 10 days prior to the procedure, and afterwards about 4 to 6 weeks not to take any NSAIDs. I kind of like, for anybody who's had using steroids or had steroid injections, I have a 30-day rule. I say that you shouldn't have any steroid injections 30 days prior and 30 days after. But I'm not sure how much is supported by evidence. It's not, but I try to, same thing that we were talking about. I want to make sure that they get the appropriate immune response as much as possible for the treatment that we're utilizing. Interactions with other treatments are important too. I believe people who are anticoagulations, even some of the diseases, people who have autoimmune disease, or people who have a chronic immune modulating treatments. I'm not sure how. We don't know that we out there it's a contraindication or not, but obviously the efficacy of it is questionable. And so if they are on chronic treatment for these type of medications, the efficacy of the treatment might be not as optimal that you're expected with other patients.
This talk was riveting. I know we've been on here and we have to wrap up this. I could speak with you for hours, as many of our listeners could. I think this is an emerging topic in the field of pain medicine. I think the gist of this is that you should come to the course, definitely the MSK course. I think for our ASRA members, you should join the SIG. I do think this is a large future of medicine. And even in the past decade, we've seen so much growth and new information on the topic. Anything else you guys, last parting moments before I close out? Because if not, we'll be speaking about this for hours, which I would love, but my family might kill me.
Would like to thank ASRA and you, Gary, for the opportunity to discuss this. It's a hot topic. It's a lot of interest, and it's a future of medicine. One of those futures. Let's put it this way.
Your SIG has done a great job. I can't wait to get more involved. I think we're going to have to bring yourselves and some other leaders of your SIG back for a second round, because this is just so interesting. Again, this is the Regenerative Pain SIG. We could see over here, we have Christine and some of her colleagues teaching the pain medicine and MSK ultrasound course in Chicago. And hopefully we'll see you guys in the spring at the meeting. Again, 2 more days for the early bird special. The Diplomat is a world-class hotel and world famous. So thank you to Yashar, Thomas, Christine, and Dmitri. This was fabulous. I can't wait to see you guys again soon so we could have some banter over some coffee.
That's great. Thanks,
Have a good evening.
Thank you, Gary. Good to see everyone. Good night, everyone.
Thank you. Good night, everyone.
Thank you, guys. Cool.